The important word in the title is the word we. And what do I mean or you mean by the word we in the title? And if you look at what word means in English, there's lots and lots of definitions. You know, there's the royal we. So the Queen can never say I. She has to say we, because she's representing the country. And then there's others, authors we's, a kind of patronising we. And then, of course, you go into a different language and we means something completely different, all right? So it's really about the definition of what we mean in this title when we say, do we really need drugs? And the answer, following our neurologist friend, is to say both yes and no. And you could say yes or no, but it's from different people. So I think if you ask doctors or healthcare professionals, do we really need new drugs? The answer is no. But if you ask patients, do we really need new drugs, then the answer is probably yes. You know, we have a big choice of antiretrovirals as doctors to decide how we can individualize these to give our patients the best outcome. And we have to think as doctors, what are we really trying to achieve? And over time with antiretroviral therapy, the definition of success and what we are trying to achieve has changed. And of course, it's gone through things like numbers, such as an undetectable viral load, normal CD4 count, to reducing transmission, to increasing quantity and quality of life. And I think if you look at the results of trials, of cohorts, of clinical practice, as doctors, with the drugs, we can do all of these things. And in some ways, the doctor's work is over. You know, we can achieve all those things. Just patients are coming into our clinic and they say, what's my viral load? I say, undetectable. What's my CD4 count? Normal. Anything wrong with you? No. And off they go. They're very, very happy. You know, the drugs are working fantastically. Having said that, of course, this last factor, quality of life, isn't just about numbers and undetectable viral load. There are many, many other factors which we all have to work on at various different levels to really improve the quality of life of individuals living with HIV. The other thing to remember is doctors and patients do not think exactly the same. So this is a study that one of our doctors did where they just gave 10 attributes to antiretroviral therapy to healthcare professionals and to patients. And you can see, although there was some things that were the same, such as efficacy at the top, cost at the bottom, in between, things were very, very different. So I'm not going to think about these things, I'm going to think about these things and how the patient actually ranks what they want from antiretroviral therapy and whether we can improve things. And I think we've come away a lot from the old days where it was doctor knows best, much more towards patient knows best, and the role of the healthcare professional is to give the patient information so that they are informed enough to make their own choices. So if we start at the top and think about efficacy, how efficacious are the drugs? We were talking about necessity of hepatitis C drugs to reach 90%. You'll be aware that the latest clinical trial to come out, bictegravir versus dolutegravir, this is the phase 2 study, showed virological success in over 90%. You'll be aware that at the IAS, the phase 3 study of dolutegravir versus bictegravir will be shown. You may also be aware that there was a glitch on the IAS website, and you could actually see, did you know that, Maro? And you could actually see the results of the abstract. So I'm not going to tell you the results, but both of them are over 90%. So, you know, we've got fantastic drugs that actually work, which give virological success. But again, the question is, that's clinical trials. What about clinical practice? But again, if you look at cascades of care, this is the UK cascade of care, looking at every patient on treatment. So it's not just naive patients, it's every patient, and it's over 90%. And even in countries which have had very poor cascades of care, such as the United States, you may have seen the cascade for New York, which now shows this number over 90%. So I think there's no question that we have drugs that work against the virus and we get immune reconstitution. What about protection of others? They want to take drugs, which means that you are not going to transmit virus. virus, again, I think we've come a long, long way. I'm going to agree with Pedro rather than with you, Mara, that I think the most important thing is treatment as prevention. We've come a long way from just lecturing people from abstinence, and clearly there are a lot of other things towards HIV prevention. But the great thing about treatment as prevention is if you get patient diagnosed, get them on treatment, get them on successful treatment, it doesn't matter what you get up to, the risk of transmission comes down or estimates or probably is zero. I think the important thing there is treatment as prevention. Although patients want it, they're not all that altruistic. This is before the START study, so before there was a benefit to the individual of taking antiretroviral therapy early, but not all patients would have taken therapy just to prevent transmission to others. So I think it's really important that treatment as prevention is probably the most effective preventive mechanism that we have, but we need to be aware it's not right for everyone, and we need to continue to study other means of prevention. I think the big issue is toxicity. Toxicity is the big issue. And if you think about how antiretroviral guidelines have developed and how success has developed, it's actually just mirrored toxicity of drugs. So if we think about toxicity of drugs, that there are many different forms of it. We're aware that there are toxicities which may happen acutely, immediately when patients may take these drugs. There are short-term toxicities that can resolve. There's then chronic toxicity, cumulative toxicity, which is made up by the more of the drug we take, the more chance that the patient will develop toxicity. And of course, there is always the important thing of unknown toxicities. No one's got a crystal ball that can look into the future and say this drug is perfectly safe. So thinking about nucleosides, if you think about how we've changed guidelines for nucleosides, it's just been about toxicity. So you'll be aware AZT with GI disturbance, blood transfusion, and then this fantastic drug came along, stavudine. And of course, then stavudine had toxicities, peripheral neuropathy, lipoatrophy. We went back to AZT, but then that caused lipoatrophy. We then had this new wondrous drug, abacavir, but that was associated with hypersensitivity, with possibility of cardiac events. Then it was tenofovir. Then we're told tenofovir has renal toxicity, bone toxicity, and we're left with TAF. And TAF, of course, has no toxicity at all, or at least that's what we're being told at the present time. The same with non-nucleosides. You know, we started off with nevirapine and severe toxicity, toxicity of the skin, toxicity of the liver. Then we moved on to efavirenz, the new wonder drug, but that was associated with CNS disturbance, with suicidality, and then we moved on to rilpivirine, again with no toxicity. And the same with protease inhibitors, indinavir and all the issues with indinavir, then Kaletra, but then Kaletra had GI disturbance, body shape changes, and now we're on to darunavir, again with no toxicity. So we're told we've now got very, very safe drugs. And of course, we've also got a new class of drugs, the integrase inhibitors, which again have really taken over guidelines, not only because of their efficacy, but possibly because of their lack of toxicity, which is associated with the patient's ability to adhere to those drugs. And I think that's what's really important when we look at the success of therapy. It's about having tolerable drugs, driving adherence, driving the efficacy. And this is an old slide which we used to show many years ago, but I think it sums up when we're thinking about TAF, when we're thinking about rilpivirine, when we're thinking about other new drugs, they start off as a god. You know, they are something which is fantastic. And then something happens and they change to dog, which means I wouldn't even give it to my dog. And then it comes back to reality. And we're aware that each of the drugs that we give can have toxicity. And I think that's important because with time and exposure to new drugs, we see toxicities developing. So this is an old slide from Andrew Carr, but I think a really useful slide, just showing how long it took us to recognize toxicity with different drugs. So just because we think we've got drugs which are safe now doesn't mean that we will have drugs which are safe in the future. And therefore, this is one of the big drivers to the reasoning behind why we should be thinking, at least for the patients, of the need for new drugs. And of course, if you take dolutegravir again is going through a bit of a dog phase. It's clearly a very good drug, but we're starting to see toxicities. You may be aware last week the French reported abnormal weight gain with dolutegravir. I've just seen a patient exactly the same, and when I bring it up on the wall round, someone else says, I've just seen one like that as well. So, you start over time, these drugs with no toxicity potentially do have a toxicity. The CNS disturbance with dolutegravir is being more and more reported and has been associated with higher levels of dolutegravir in a Japanese study. And I think what's important when we look at toxicities is that you can't look at short-term clinical trials and say a drug is going to be safe in the long term. If you look at the results of the clinical trials with dolutegravir and the development of different CNS toxicities, there seems to be no difference compared with other agents. However, you'll be aware of studies such as the Dutch study looking at individuals who were starting a dolutegravir-based therapy, and the relatively high number who stopped dolutegravir at a relatively early stage. And if we look at the reasons for interruption, you can see the reasons, the toxicities, sleeping, GI disturbance, neuropsychiatric. So there does appear to be a signal of possibility in a small number of patients of CNS disturbance with dolutegravir. Then we have the issue of cumulative drug effect, i.e. the more drug you put in your body, the more chance of developing toxicity. And I suppose if you think back, that's exactly what we saw with AZT, with D4T, and the development of lipoatrophy. And I think this is a nice slide which David Back showed last week at one of Charles's conferences, just looking at the amount of drug that people are putting into their body on a yearly basis. And you can see, there's quite a lot of foreign material that people are putting in, so it shouldn't surprise us that we're likely to get toxicity in the future. And I think that is why we're looking now at 2 drugs rather than 1 drug. I certainly look at my 3 younger children and think, rather than a kind of triple therapy, how much nicer it would be if there was just 2 of them, or perhaps 1 of them, or on some days none of them. Certainly the majority of it is due to toxicity, and clearly we've looked at reducing to 1 drug, the PIVOT study, PI monotherapy, and the high rates of PI of failure, viral replication, and of course that is then associated with a replication. Now, we can rescue that by adding back in nucleoside analogues, but it's the same on a meta-analysis, that if you look, it's actually PI monotherapy certainly doesn't work. If there's replication, there's going to be inflammation, there's going to be a risk of transmission. We've then, of course, looked at dual therapy. This is just one example of 2 strong drugs, a protease inhibitor and an integrase inhibitor, versus 3 drugs, and the 2-drug regimen failing. And we've got lots of 2-drug therapies which have failed. We've got some based on 3TC which have succeeded, but I'd say it's a common sense. It shouldn't come as any surprise. If you base your dual therapy on 2 drugs, it's unlikely to work. And the reason it's unlikely to do as well is we know that the persistence of PI therapies as triple therapies, because of their toxicity, perhaps some inherent weakness as regards efficacy, is that they don't do as well. So success is going to depend on your backbone, and I think we've moved away in guidelines from backbone being the nucleosides to integrase inhibitors, and I can go through these quickly because I'm sure you've seen these before, but we've got a good data coming through that 2 drugs based on an integrase inhibitor, both in naive patients in the PADDLE study and in the SHIELD study, looking at 2 drugs, dolutegravir and rilpivirine, that we may be able to get away with using 2 drugs rather than 3 drugs with good virological success and the potential, therefore, to reduce toxicity. What about resistance if patients fail? Well, again, with integrase inhibitors and indeed protease inhibitors, we have a high genetic barrier to resistance, but we also need to think about those people who have survived with this kind of multiple resistance and whether new drugs may be able to simplify their regimens. There is the development of new antiretroviral agents out there. This is just one of them, an attachment inhibitor from GSK, which has shown equal efficacy in individuals with double-class experience and resistance as treatment with atazanavir. So we have got the need for new drugs for these individuals who are on difficult-to-take regimens. Drug-drug interactions, again, is going to be important in the future. We've been told, and this isn't in HIV, but in HIV-negative individuals, if you have one comorbidity, you're much more likely to have two comorbidities or more, and that is even more prevalent in an HIV-positive population. And due to perhaps poor communication, poor knowledge, the number of drug-drug interactions potentially in HIV-positive patients may be very large. But again, with the advent of integrase inhibitors, it's become a lot safer as regards drug-drug interactions. Finally, adherence, and I think here, we need to move away from the idea of one drug once a day towards long-acting antiretrovirals. And of course, we've got long-acting antiretrovirals coming. We've already seen results from the LATE-2 study looking at injections of carbotegravir, either 4-weekly or 8-weekly, with rilpivirine injections 4 or 8-weekly. The same positive results in a population who were treated with oral agents. And if you ask the patients, many of the patients felt that it was an improvement on taking tablets a day to take these injections 4 or 8 weekly. I think we have to be careful. Is this going to be the right combination for everyone, these long-acting antiretrovirals? We know that there are differences between individuals in pharmacokinetics. And if you look at one of the subjects in LATE-2 who failed, it seems to be certainly related to a reduction in the levels of the drug, which is going to be associated with perhaps the injection or the site of injection in this patient. Again, when we look at these long-acting agents, they're going to have a very long tail. This is one of the patients in a study done at our unit using long-active rilpivirine as PrEP, and you can see the tail of this, and he happened to get infected after the end of study, but there was still rilpivirine present, and he therefore almost immediately developed non-nucleoside resistance. So this long tail, I think we need to be aware that these long-acting preparations are great for adherent patients, but not for patients who are not going to return to the clinic. We have other long-acting agents. We have a nucleoside from Merck, which may be able to be dosed, perhaps once every 6 months, and people are looking at an implant for this, which may have added advantages in case of toxicity where the implant can be removed. There are also going to be TAF implants and a move towards nano formulations being developed by multiple companies, which will allow easier administration. Finally, cost. And I think we can't move away from cost. We can talk about we want new drugs, we want new preparations, but they're all going to cost money. And of course, we're being bombarded, at least in the Western world, with generics, or wherever you are, by a pressure to use the cheapest drugs you can. And it saves millions. This is data from the United States looking about a movement towards generic antiretroviral therapy. This paper was about 2 or 3 3 years ago, but it's saved around $920 million per year. So we're talking about needing money to roll out hepatitis C treatment. There is a finite amount of money, and we need to decide how best to use them. But within HIV, we mustn't forget all the fight that has gone on and the value of human life. And we're only in the position where we are due to, and we heard this earlier from one of the ladies in the audience, from activation from our patients putting pressure on. And I'd hate to see it that we're going to go back to days of this kind of demonstration when we've achieved so much already. Thank you very much.